distinguished guests, ladies and gentlemen. Assalamu alaikum and a very good morning. As a moderator, I must introduce myself first. I am Dr. Imran Ali Sayyed, working as Transplant Hepatology Fellow at Pakistan Kidney and Liver Transplant Institute. On behalf of PSH, I warmly welcome you all in this morning session of the third day of 22nd Annual Conference of PSH. As you are all aware, this session is about free papers and a quiz session for postgraduate residents. First, there will be a paper presentation and then we will move to the quiz competition. Facilitator for this session is Professor Kashif Malik. He is currently working as Head of Department of Gastroenterology at Sheikh Zayed Hospital. We have some well-renowned gastroenterologists and hepatologists to chair this session. It gives me great pleasure to introduce the first chairperson, Professor Altaf Alam. No words are enough to compliment him, and he does not need any introduction. He is currently working as consultant at Evercare Hospital and has worked as head of department at Postgraduate Medical Institute, Sheikh Zayed Hospital, Lahore. Our second chairperson is Professor Lubna Kamani. She is professor and director of GI residency program at Liaquat National Hospital. Currently president of Pakistan GI and Liver Disease Society. Co-chair woman in hepatology forum SASL. Publication secretary at PSD and member of WGO global for guideline committee. Moving to the paper presentation, we must remember the rule that every presenter must finish the presentation within 8 minutes, and it will be followed by 2 minutes session of question and answer. Our first paper will be presented online, and we are very delighted to have international participation in our free paper session. Let me introduce our next participant, Dr. Eugene Wong from Singapore. Dr. Wong graduated from Faculty of Medicine, National University of Malaysia in 2010 before obtaining his Master in Medicine from National University of Singapore in 2013. Currently, Dr. Wong is a consultant at Department of Gastroenterology and Hepatology at Shanghai General Hospital, and he is also a social media member for Easel News. He has about 20 publications on different topics in field of gastroenterology and hepatology. Today, he will present chess alarm score to predict liver decompensation in compensated cirrhotic patients. Dr. Eugene, can you hear us?
Hi, good morning. Thank you very much. First of all, allow me to congratulate the organizing committee of the 22 Annual Congress of Pakistan Society of Pathology for putting this wonderful meeting together. It's a pity that I cannot join in person. I would also like to thank the organizing committee for the opportunity to share our work in this meeting. Is it possible to allow me to share my screen, please?
Yes, go ahead.
Still unable to share the screen, unfortunately. Oh, okay, that's great. May I know if you are able to see the screen?
Yes, we can hear you now.
Alright, fantastic. So on behalf of my collaborators, I'll be sharing the abstract title, Chest Alarm Score to Predict Liver Decompensation in Compensated Cirrhosis Patients and the International Multi-Center Study. I have no disclosure related to this presentation, and I'm currently working in Changi General Hospital, Singapore. So we know that liver decompensation is an important clinical endpoint in compensated cirrhosis patients, and mortality dramatically increases as patients transition from compensated cirrhosis to decompensated cirrhosis. While hepatic venous pressure gradient (HVPG) is considered the gold standard to predict decompensations, it is limited by its invasive nature and accessibility in our daily clinical care. So currently, it remains uncertain how we could accurately estimate the individual risk of liver decompensations in compensated cirrhosis patients. This remains an unmet clinical need. And moreover, The current dichotomous risk stratification into just high and low risk per se may not accurately reflect the evolving risk of decompensations over time. Therefore, the aim of our study is then to validate the performance of non-invasive criteria to predict liver decompensation in the real-world setting. We also aim to develop a predictive model to refine the risk stratification of decompensations in compensated cirrhosis patients. To do that, in this study, we included an international cohort of compensated cirrhosis patients, retrospectively from Singapore and China. All patients have had liver stiffness measurement and gastroscopy performed within 6 months. We subsequently correlate the baseline characteristic of these patients to our study outcome, which is first the time to decompensation and also the transplant-free survival. In this study, we excluded patients with prior decompensations, hepatocellular carcinoma, and patients with uncontrolled underlying etiology. At baseline, the number of SPECT gastroscopy between Baveno 6 and expanded Baveno 6 criteria were compared using the MAGNIMA test. And on follow-ups, we also compared the performance of non-invasive criteria to predict liver decompensations using competing race analysis with death and liver transplantations as the competing events. We subsequently developed the CHESS RM score to refine the risk of liver decompensation among compensated cirrhosis patients. All baseline univariate variables that are significant were considered for inclusions in the multivariate analysis to generate a predictive score. We then assessed our model accuracy using time-dependent area under the curve, AUROC, and to determine the optimal cutoff to predict liver decompensations at 3 and 5 years. And finally, we also perform an a priori subgroup analysis based on the age, BMI, etiology, as well as the usage of non-selective beta blocker, because we know that non-selective beta blocker usage significantly changes the natural history of compensated cirrhosis patients, particularly those with clinically significant portal hypertension. In this study, we defined compensated advanced chronic liver disease, or CACLD, as having liver stiffness measurement of 10 or beyond kilopascal with either histological, radiological, or clinical features of liver cirrhosis. As the standard of care, all patients will follow up at least 6 monthly until the point of first liver decompensations. In this study, to minimize reporting bias, we use objective outcomes such as clinically significant ascites requiring diuretics, variceal bleeding were all confirmed from endoscopy, and hepatic encephalopathy were defined as having at least grade 2 and beyond based on the HERAS-7 classifications by specialists. So here comes our results. This is a baseline characteristic of our study subjects. We included 633 patients from both Singapore and China. To summarize, Singapore cohort were generally older with more men and HCV infections. Singapore cohort also have a higher baseline serum creatinine, lower albumin, and higher liver stiffness measurements. The MELD score, MELD score, follow-up durations, and decompensating events were both all similar between the two cohorts, namely the Singapore and the China cohort. Overall, we found that 60 patients developed decompensations over a median follow-up of 39 months. The cumulative incidence of liver decompensation at 1, 3, 5 years was 0.7%, 6.1%, and 17.6% at 1, 3, 5 years respectively, with ascites being the commonest decompensating events, which is consistent with the literature. The overall transplant-free survival among these compensated cirrhosis patients at 1, 3, 5 years was 97.9%, 94.9%, and 91.5% respectively. We found that compared to Baveno 6 criteria, the expanded Baveno 6 criteria, as expected, spread more screening OGD compared to Baveno 6 criteria, but this is at the expense of missing out more high-risk varices and esophageal varices, even though both criteria miss less than 5% of high-risk varices. But when expanded Baveno 6 criteria was used to predict the risk of decompensations, expanded Baveno 6 criteria will miss more patients at risk of developing decompensation, particularly ascites. The risk of developing hepatic encephalopathy and variceal bleeding was similar between the two criteria. And as you can see, the performance of this expanded Baveno 6 criteria and Baveno 6 criteria were generally comparable between both the Singapore and China cohort. While both criteria has good negative predictive value and sensitivity to exclude patients at risk of decompensations, they were suboptimal to predict liver decompensations with positive predictive value of less than 20%. Therefore, to better identify patients who will develop decompensations, we developed the CHESS alarm score. So how do we do it? First, we identify clinically relevant baseline variables from univariate analysis to be included in the multivariate analysis. The final score consists of 5 variables, namely the age, liver stiffness measurements, platelet count, INR, and AST more than ALT ratio. These variables were selected based on clinical and statistical significance in order to optimize the model accuracy. All the 5 multivariate variables were then included in a weighted predictive risk score, and the equation was stated on the left side of the screen. On the right, we found that the optimal cutoff to categorize patient into high and low risk was chest alarm score of 1.6. You can see that from the figure on the right, chest alarm score beyond 1.6 separate the cohort into high risk and low risk very clearly, as shown on the figure, with a high risk group having a 12-fold higher risk of decompensation compared to the low risk group. You can see that this cutoff of chest alarm score 1.6 has good performance to predict decompensation. Not only that chest alarm score has excellent sensitivity and negative predictive value, it also has an improved positive predictive value compared to the expanded diagnostics criteria and diagnosis criteria to predict compensated cirrhosis patient who will develop decompensation. The chest alarm score also accurately predict the cumulative risk of decompensation at 1, 3, and 5 years respectively, as shown here, with an ALRC beyond 0.8 at all time points. You can see that it was also superior to other non-invasive criteria such as platelet elastography criteria, LB, LB FIT4, MELD score, and liver stiffness measurement at various cutoff of 20, 25, and 30, both numerically and statistically. Furthermore, we subsequently categorized the score into 4 grades depending on the score decile using the cutoff as shown on the left side of the screen. As you can see on the right side of the screen, we see that the cumulative incidence of decompensation further increased progressively from grade 1 to grade 4 with 4 different and very distinct lines in the figure, suggesting that the risk of decompensation increases proportionally as patients progress from grade 1 to grade 4 of chest alarm score. Why do we do that? Is because by categorizing patients into different categories, we can now identify nearly 2/3 of patients with very low risk of liver decompensation with only 3.2% at 5 years. But at the same time, we are able to identify a small proportion of high-risk patients as shown in chest alarm grade 4 with a 5 years decompensation rate beyond 50%. Furthermore, in an a priori subgroup analysis, you can see that the performance of chest alarm score remained robust when subgroup analysis was performed based on center, based on age, BMI, etiology of a viral versus non-viral, as well as when we exclude patients who who did not receive a non-selective beta blocker at baseline. The performance remained robust with internal validations both using the original and the bootstrap samples with a Beal score of 0.12 between both the original and the validated cohort. In order to improve the applicability by the general physicians, we further developed a free online calculator for physicians which can be accessed using the QR code shown on the screen. By entering the variables, we can then know the chest alarm grade for the patient as well as the risk of decompensation at both 1, 3, and 5 years respectively. The strength of the current study is that we perform a real-world validation using a large international cohort of compensated cirrhosis patients, and we perform a competing risk analysis to adjusting for death and liver transplantation as competing events to liver decompensations. And with that, we actually developed the chest alarm score to estimate the individual time-dependent risk of liver decompensation. And finally, we also created an online calculator to improve applicability for this score. All study has limitations. In our study, we are subjected to the limitations from the retrospective studies and reporting bias. Nevertheless, the outcome were objective, and these outcomes are easily replicable and repeated out. And because we only included a small cohort of NASH cirrhosis patients in our cohort, only about 10%, therefore external validation is required among NASH cirrhosis patients. So, ladies and gentlemen, to conclude, the chest alarm score is an accurate, non-invasive tool that can easily incorporate into our daily clinical care to estimate the individual risk of liver decompensations. And I would like to take this opportunity to thank the support from the department and the funding agencies to allow me and time the resources to pursue my research training. And with that, I thank you very much for your kind attention. I'll be happy to address any questions that you may have. Thank you.
So now we'll take some questions. Audience.
Online we have Dr. Amara Naveed having a raised hand. Online ले लें उनको please.
Dr. Amara, can you hear us? Dr. Amara, can you hear us?
Dr. Amara, can you unmute yourself and ask your question, please? Excellent work, Dr. Wong. I must congratulate you for giving us a model and also making it available online for us to use it. Thank you very much. My practical question is, how do you see this model working in clinical practice? Do you, those with the high score, would you follow them up more closely, maybe every 3 months rather than 6 monthly? Or what? What do you see? Thank you.
Good morning, and thank you very much for the questions. So how I envision this sort to be used is that I think for those patients with grade 1, they have very minimal risk of decompensations. So in such patients, I probably will not consider using non-selective beta blocker in these patients because the risk of decompensation is low. Even with a delta of risk reduction of 50%, it merely reduces the risk from 3% to 1%. So I think this patient, the absolute benefit of a chest alarm grade 1 patient receiving non-selective beta blocker will be low. And conversely, if let's say you are chest alarm grade 2 and beyond, these patients has a substantial higher risk of decompensation. So if one were to consider using the non-selective beta blocker without HPPG, perhaps it is reasonable to consider non-selective beta blocker used in chest alarm grade 2, 3, and 4. Intuitively, patient with chest alarm grade 4 has a high risk of decompensations. What is lacking is that we do not have the median times to decompensations to really answer the question whether is closer follow-ups beneficial to this patient. But it will be intuitive that this patient are at high risk of decompensation. Definitely NSBB is a must if let's say there's no contraindication, and potentially if the resources are available, we generally prefer to monitor these patients more closely. And also, if let's say I'm conducting a clinical trial, potentially I will use, to reduce the sample size, I will probably use this chest alarm score and recruit more patients with a chest alarm grade 4 so that there will be more events and I only require a smaller sample size to run my clinical trial.
Thank you. Any other question or comment? If we can't have Dr. Amara, we can ask.
An excellent talk. What about, are you planning to do a prospective study on this model? It would be a very handy in a day-to-day routine clinical practice, and also to expand your research to other countries, because our demographics might be different from, Far East patients. The South Asian demographics are different. The etiologies are different actually. So are you planning to do a prospective multi-center with expanded, beyond Singapore and China boundaries?
Thank you very much for the great interest. Yes, we are hoping to conduct a prospective study, but currently we are still limited by the resources and the funding for this particular chest alarm score. We do have collaborations with other countries that we recently just published by validating this Bermuda 7 criteria using platelet and elastography. We validated the performance of Bermuda 7 criteria to re-stratify compensated cirrhosis patients based on compensated cirrhosis patients from 4 countries, including Singapore, China, Italy, and India. And what we find is that, interestingly, liver stiffness measurement of more than 25 itself is actually a very good predictive value to predict who will develop the decompensation. So if anyone is interested, feel free to drop me an email. I'll be happy to share the paper with you as well.
And what about comparing your score with other already established score, the head-to-head trial, to find out more accuracy for this score, prediction of decompensation?
Yes, I think this will be very relevant. We unfortunately we don't have the resources to do this because this will involve a pretty large sample size to validate this, because we have an ease of doing this because there's really established registry from both countries. So retrospective study as such is feasible within a short time frame. But for prospective studies, which means that this is which will include a large cohort of patients, nearly 1,000 patients with a median follow-up of minimum 3 years, to start to see some delta difference in terms of the risk of decompensation, because these patients are compensated cirrhosis patients, and the risk of decompensation are generally very low without clinically significant portal hypertension. So it's a huge resources, and we really require funding from multiple countries. That unfortunately is the main challenge. But until that is ready, whichever data that we can generate will still, we believe, will be helpful to fill in the gaps for the liver community.
Thank you, Dr. Eugene. Any other question?
Let's move on.
So now
Thank you very much, Dr. Wong. Hope to see you in the next meeting here physically. Thank you very much.
Okay. So as we all know that NAFLD has been on rise, and recent meta-analysis and systemic reviews have estimated that the global incidence of NAFLD is between 25 to 30%. Patients with NAFLD have a high risk of liver-related morbidity and mortality, and they are at risk of developing metabolic comorbidities. And the therapeutic measure with the best potential for treating NAFLD is sustained weight loss by dietary changes and exercise, and addressing the metabolic complication. To discuss about some drugs that can prevent NAFLD that can prevent the conversion of NAFLD into NASH, we have Dr. Asma Abdul Razak, Assistant Professor at Medicare General Hospital, Karachi. She will be talking about anti-diabetic drug combination employed in prevention of NASH. Dr. Asma.
Assalamu alaikum. I am Dr. Asma Abdul Razak and currently working as a faculty member in the Jinnah Medical Dental College Associated Hospital, that is Medicare General Hospital. So it's a huge honor to be here as a presenter in the Pakistan Society of Hepatology 2022, and it's my huge privilege to present my research, as we have done research on two anti-diabetic drug combination that has been employed in the prevention of non-alcoholic steatohepatitis. So let's move on. So basically, the non-alcoholic fatty liver disease prevalence, as you all know, it's increasing day by day, and globally it's 25.2%. In United States, it's around 24.1%. And non-alcoholic steatohepatitis prevalence is globally around 1.5 to 6.45%. So basically, a pathophysiology of the NAFLD is when the abnormal fat accumulation in the liver, it is the and alcohol consumption is always excluded. So fatty liver, when they develop any liver inflammation and any steatosis, it will lead to the non-alcoholic steatohepatitis, and it is a reversible condition. But if the liver inflammation that progressively increases, and it will leads to the scarring and fibrosis, it will end up into the cirrhosis and eventually in the liver failure. So we have to, most likely the non-alcoholic fatty liver disease patients are asymptomatic and they are benign as well. But some patients usually present in a clinic with the upper abdominal pain, malaise, decreased appetite, and when they develop the non-alcoholic steatohepatitis, that is liver inflammation and fibrosis, maybe, so they have some itchy skin, jaundice, and maybe the decreased appetite and malaise as well. So there are some causes that may develop the non-alcoholic fatty liver disease. Is that maybe the hormonal causes? The hormonal include the ghrelin, incretin hormone, and insulin resistance. Along with that, the smoking and sedentary lifestyle. Along with that, obesity, especially in the abdomen. The other metabolic risk factors like maybe the hypothyroidism, the increased triglycerides level, and increased LDL levels. Along with that, increased BMI more than 25, and with uncontrolled blood sugars, uncontrolled glycemic control, and HbA1c more than 7 or maybe 8. So altogether, the non-alcoholic fatty liver disease may develop the osteoarthritis as well, maybe the vascular disease because of the deranged lipid profile, and the cardiac disease as well, and eventually in females they are very common, the polycystic ovarian syndrome, and eventually the kidney diseases as well because of the uncontrolled glycemic control. So we have given the two medication combination that I'll let you know, that empagliflozin and the linagliptin. So combination therapy currently available will probably lead to the better effectiveness in the future by addressing a variety of key pathways in the development of the NASH. So the empagliflozin, what is the mechanism of action? So basically the empagliflozin, it works by inhibition of sodium glucose cotransport 2, and that found in the proximal tubules of the kidney, that reduces the reabsorption of the glucose and increase the urinary excretion of the glucose. And it also interfere with the changes of the liver histology by interfering the lipid metabolism and the glucose and the insulin secretion and excretions and resistance. So, and linagliptin is basically works by inhibiting the DPP4 that degrades the incretin hormone. That incretin hormone is basically the gut hormone that stimulates the insulin after eating, and regulates the insulin as well. So combination of these two drugs with a healthy diet and regular exercise is used to treat diabetes related elevated blood sugar levels, and additionally it helps individuals with type 2 diabetes, heart diseases, and blood vessels reduce the risk of mortality. So we have done a quasi experimental study, and it was designed at the Medicare General Hospital. So we have taken 150 diabetic patients with the liver disease. With the selection criteria, as I already told you, the BMI was more than 25. The patient had deranged LFTs in which ALT and AST more than 2 upper limit. The triglycerides level were more than 250. Hypothyroidism. The patient were having a sedentary lifestyle, but we exclude the patient who were pregnant and having any kind of sepsis or maybe the malignancy and allergic reactions or any hypersensitivity reaction regarding the drug, because the linagliptin can develop hives and allergic and hypersensitive reactions. So our intervention was baseline findings on we gave empagliflozin and empagliflozin and the linagliptin combination drugs in a 2 form. It's by 25 by 10 mg and 10 by 5 mg. So we given the patient empagliflozin 25 and linagliptin 5 mg combination, and we did a trial on baseline findings, and we sent the patient for the follow-up at least for 4 weeks, and we follow up the patient after 4 weeks, in which we found the result that we have patients of around age 28 to 37 years, in which males were 116, that is 77%, and the females were 34, in which HbA1c was more than 8, and 60% with BMI between 25 to 30 were diagnosed as the diabetes mellitus type 2 more than 5 years ago. So we found that pre-treatment versus post-treatment predictive value less than 0.05. So baseline findings were significantly changed with the effective and the favorable results. So here's a discussion that there is a critical need of novel insulin sensitizers because the pathophysiology of both type 2 diabetes and NASH is largely Alright, influenced by insulin resistance. So there are some other PPAR and PPAR agonists as well, but they have some constrained by safety profile. One more thing I will let you know that we have some comparison drugs as well. That is usually the metformins are usually given to the diabetic patients and sulfonylureas as well. But metformin has a few side effects that it can cause bloating, diarrhea, and maybe the metformin should not be given if the GFR is less than 30%, or metformin should be avoided in the cardiovascular disease patient. Along with that, metformin will decrease the HbA1c level less than 0.8 to 1%. And according to the recent American guidelines 2020, the first combination should be empagliflozin and linagliptin because of the safety profile that is renal and cardioprotective. The other sulfonylureas group can also be using, but it has also some side effects that it is not renal it is not cardioprotective, and it can increase the modest increase weight gain as well. So we'll conclude our study that when we give the combination, we found that the patient with the liver disease, they reduce the ALT and AST level, they reduce BMI because of linagliptin, and they reduce the triglyceride level as well. We found that the patient have reduced HbA1c and reduce the risk of progression of advanced liver disease, that is non-alcoholic steatohepatitis. And the beauty of these two drugs combination is that these are renal and cardioprotective as well. So thank you so much. And these are the references.
Thank you for a very nice presentation. And any questions? Professor Altaf.
Yes, sir. Thank you.
These drugs to be used more often in the future, and they do work not only by weight loss, but also better diabetic control and some effect on liver. Unfortunately, for any work on NAFLD or NASH to be published, you currently need some more information rather than ALT, AST, and maybe prolonged follow-up rather than 4 weeks to make any final comments. This is a lifelong disease. So my comment would be that maybe you can expand this work, good work that you have already started, by including a few good things for it to be publishable and acceptable all across the globe. Thank you.
Thank you so much, sir, for your valuable comment.
You can add a control group as well. So that will add more power to your study. So one group getting these drugs and another group without these. And you follow, as Professor Altaf said, that you have to follow this patient for longer period of duration, at least for a year, 6 months or a year.
Thank you so much, ma'am. Thank you.
Now I will move quickly to the third presentation. I will be presenting this case, this paper. I have already introduced myself. I am Dr. Imran Ali Sayed and working as a transplant hepatology fellow at Pakistan Kidney and Liver Institute and Research Center, Lahore. The topic of my presentation is paper is radiologic versus histological comparison of response assessment to pre-liver transplant locoregional therapies in hepatocellular carcinoma. So the goal of locoregional therapy in hepatocellular carcinoma is to induce tumor necrosis, and TACE among all locoregional therapies is the mainstay of bridging therapy for patients with hepatocellular carcinoma awaiting liver transplantation. However, tumor response rates are variable. So this was the objective. We wanted to compare the pre-transplant radiological response of locoregional therapy for HCC with histological assessment of tumor necrosis on explant. It was a retrospective study conducted between January 2019 and March 2022. at PKLI and Research Center. The histological response was defined based upon the previous studies. It was defined as complete when there was 100% necrosis, and partial when it was 50 to 99% of necrosis, and incomplete response was defined when there was less than 50% of the necrosis. And radiological response assessment, as we all know, it is checked or verified with modified response evaluation criteria in solid tumors. So I'll quickly go through this slide. Complete response is when there is disappearance of any intra-tumoral arterial enhancement in all target lesions. Partial response is at least a 30% decrease in sum of diameters of viable, which is the enhancement in the arterial phase of target lesion. And the stable disease is the one who does not qualify for either partial or response or a progressive disease. So if a patient has less than 30% decrease in the viable tumor, that will be considered as a stable disease. And for progressive disease, an increase in at least 20% of the sum of the diameter of viable target lesions is considered as progressive disease. So here, if a patient has at least 15% increase, he will not be considered as a progressive disease. So all liver explants with history of locoregional therapy for hepatocellular carcinoma along its radiological response assessment at least 6 weeks post therapy were included, and the explants who were not assessed, patients who were not assessed radiologically prior to liver transplantation were excluded. Total 240 liver transplants were performed during this duration, and HCC was found in 22.91% of patients, and explants with history of local regional therapy were 40% among those having HCC. Median age was 55.5 with a range of 40 to 70, and the male gender was predominant. Etiology included hepatitis C virus in 72% of patients, B in 9%, co-infection with hepatitis B and C in 4.5% patients, and cryptogenic cirrhosis in 13.63% of patients. TACE alone was done in 77%, microwave ablation in 4.5%, radiofrequency ablation, and the combination therapies were all done in 4.5% of patients. So histological response, complete response was observed in 45% patients, partial response in 27.5% of patients, and incomplete response in 2.5%. When we compared them with the modified RECIST criteria, the tumors which were assessed in pre-transplant evaluation, the complete response was in 40.9%, partial in 40.9%, stable disease in 13.6%, and progressive disease in 4.6%. So here we made the comparison. The radiological and histologically, concordance was found in 59.19% of patients, and underestimation of tumor response was 18.18%, and overestimation in 22.72% of the patients. So radiological response to locoregional therapy for hepatocellular carcinoma may not be adequately assessed using the modified RECIST criteria in 1/3 of the patient, and advancements need to be made in radiographic assessment of tumor necrosis. Thank you. So any question?
Not right. Is that correct?
No, sir. Complete necrosis was achieved in most of the patients, but sometimes radiological response cannot be assessed as there is some limitation in modified RECIST criteria. Like if a patient has 25% of necrosis, they will consider it as a stable disease. However, he still had some response in the tumor diameter or tumor arterialization. And similarly, for the progressive disease, it has to be more than 20%. But if a patient has increased diameter of more than 50, like 15%, so they will still consider it as a stable disease, not as a progressive disease. So these are some limitations which I figured out.
Bilal, you are from an institute that really started this downstaging process at UCSF. What do you think? You go for radiological assessment, and how good is it?
I think it is definitely need improvement. There are a lot of other biomarkers that we are looking at it in addition. So in addition to alpha fetoprotein, we are looking at alpha fetoprotein L3 fraction and DCP, because the future is the biomarker also, because we have seen that patients who even has some radiological improvement, but their tumor markers are increasing, those are patients at increased risk of progression. But in our, the radiological assessment is pretty, but we do have microvascular invasion. We still see histologically, and so there's still need for improvement. But it's just the quality of scans ultimately. And we review all the scan and tumor board together, and they are even in America we see such a disparity of the imaging done outside our centers and other centers that those does not have the right phases. So I think that is also an important part of it.
Thank you.
Thank you.
Thank you very much.
Now I will move on to the next talk. It will be delivered by Dr. Shitba Naeem, postgraduate medical resident at Jinnah Postgraduate Medical Center, Karachi. She will be talking about risk factors contributing to in-hospital mortality of patients with advanced chronic liver disease.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. I'm Dr. Shadba Naeem, resident at the JPMC Ward 7, Medical Unit 3. Here I'm going to discuss the risk factors contributing to in-hospital mortality of patients with advanced chronic liver disease. Advanced chronic liver disease is known for its high risk of mortality, especially when associated with acute decompensation and its complications. Due to poor outcomes in patients hospitalized for liver cirrhosis complications, the risk factors must be identified so that prior measures can be taken to reduce morbidity and mortality. ACLD was defined as a derangement of liver functions due to fibrosis manifested by the development of ascites, upper GI bleed, hepatic encephalopathy, or hepatorenal syndrome. The MEL sodium score was defined as the severity of ACLD using serum bilirubin, creatinine, INR, and serum sodium to predict prognosis. Our main objective was to determine the risk factors contributing to in-hospital mortality in patients with ACLD. It was a cross-sectional study. It was conducted for a duration of 6 months from January 2021 till June 2021. The sample size was 209 patients and it was being conducted in JPMC Ward 7 Medical Unit 3. All the patients with ACLD given consent between ages 12 to 80 years were included in my study, whereas the patients with comorbid conditions or malignancies were excluded. So here I am going to discuss the results. These were the baseline qualitative characteristics which included the gender, etiology, and CTP scores. It was found out that gender and CTP scores were statistically significant. I'll discuss it here in the graphical representation. On the left side, we can see the gender, the mortality was higher in the female gender, whereas on the right side, as per the CTP score, the highest rate of mortality was being seen in class C, followed by class B, and there was no mortality seen in class A CTP. These were the baseline laboratory characteristics of the patients. There were certain characteristics out of which age, the white blood count, bilirubin, the electrolytes sodium and potassium, and MEL sodium was found to be statistically significant. On applying the odds ratio, we found out that the age, male gender, serum sodium, and MEL sodium were significantly associated with mortality. It was found out that older age, low sodium, high MEL sodium, and female gender was associated with high mortality, whereas male gender and high sodium was associated with less number of mortalities. Whereas we saw that on multivariate analysis, sodium proved to be the independent risk factors. So out of all these conclusion, we concluded that according to our study, male gender, low sodium and male sodium score were significantly associated with mortality. Out of these factors, serum sodium was observed to be the independent risk factor in predicting mortality in the patients with ACLD. Therefore, the patients with ACLD must be critically monitored for the risk factors to prevent the in-hospital mortality. These were the references from where I took the data. Thank you very much. Any questions, sir?